I'm Dr. Ken Landau. Thanks for watching. Let's talk about Pamelor or Nortriptyline. Now, this is a tricyclic antidepressant, was patented 1962, introduced for the treatment of depression in 1963. Food and Drug Administration approved it in 1964. It's considered a first-generation antidepressant. It's a relative of amitriptyline, and as a matter of fact, amitriptyline that you take is metabolized in the body to nortriptyline. Going back to the 1950s and 1980s, we didn't have much in the way of treatment for depression. We had the MAO inhibitors and the tricyclic antidepressants, drugs like nortriptyline, but those were largely replaced in the 1980s and 1990s by the SSRIs and the SNRIs. Well, in the tricyclic antidepressant family, we have drugs that are in common use still. We have nortriptyline or Pamelor, we have amitriptyline or Elavil, imipramine or tofranil, we have anafranil or clomipramine. We also have luteamil. Now, the drugs are principally prescribed for depression. That's what they're indicated for, depression. While all depression seems to respond to the drugs, they seem to work a little bit better in more endogenous depression, or we call it melancholic depression. These are people who have the depression and markedly diminished interest or pleasure. They're slow and flat in the morning. They show little emotional expression. They sleep badly, wake early, they have difficult time concentrating. They often think about suicide, but the drugs also used to treat ADHD, the attention deficit hyperactivity disorder. The other drugs that we have available for ADHD are stimulants. Well, nortriptyline might be especially helpful in people who have anxiety and depression related to the ADHD, and remember, psychiatric diseases seem to go in pairs or triplets or quadruplets. Also helpful if you're taking a stimulant and it interferes with sleep. Seems to be more effective in people who have the hyperactivity or the impulsivity than people who have a problem with attention, but they're not approved for a pediatric age group. Drugs are also used off-label for treatment of anxiety and panic and obsessive compulsive disorder and social anxiety disorder. Sometimes they're used for PTSD or chronic pain, neuropathic pain, fibromyalgia. They're used to help people stop cigarette smoking, used for irritable bowel syndrome and for prevention, not the treatment, but for the prevention of migraine headaches. They're used for Tourette's syndrome or people who pull their hair out, a condition known as trichotillomania. Women who suffer from interstitial cystitis, the irritable bladder syndrome, people with narcolepsy or a pathologic laughing and crying condition, people who have chronic hiccups or anorexia nervosa or temporomandibular joint syndrome. And in the United Kingdom, England, it's used for a period of up to 3 months for nocturnal bedwetting. Can be used for insomnia. Seems to improve sleep in some individuals, but in the short term it might disturb the sleep as far as neuropathic pain is concerned. Now we're talking about neuropathic pain, not the typical pain that you get because of damaged tissue. Like when you bang into a drawer, you have osteoarthritis. That's a different kind of pain. We're talking about the neuropathic pain that presents as shooting or burning or stabbing pain, the pain that you would get in diabetic neuropathy or post-herpetic neuropathy after you have the shingles. In neuropathic pain, some evidence shows that it seems to be valuable at a relatively modest dose, anywhere between 50 and 100 milligrams, but studies were small. Sometimes the dose for neuropathic pain is less than the dose for depression. Seems to be that nortriptyline is equivalent to gabapentin or amitriptyline. Evidence-based guidelines. The International Association for the Study of Pain says, hey, this is a first-line treatment. The Cochrane collaboration in 2015 reviewed all the evidence and said, no, it's not. The Canadian Pain Society in 2017 said, well, if you're going to use a tricyclic antidepressant for neuropathic pain, maybe a secondary amine, a drug like either nortriptyline or dizipramine, seems to be better tolerated in terms of sedation and postural hypotension when you stand up. Sometimes people get a little bit dizzy because the blood pressure falls. seems to have less anticholinergic effect, doesn't dry your mouth as much, doesn't interfere with bowels, doesn't interfere with the urination as much, compared to the drugs like either imipramine or amitriptyline. Well, it's used for migraine headaches. Now, the interesting story about migraine headaches is 50%, by some estimates, of people with migraine headaches suffer from either anxiety or depression, and it seems that for those individuals it might be especially useful to help prevent the headaches, even at a low dose, a dose of anywhere between 10 and 50 milligrams a day, but it's not really well studied. It seems that if you're taking it to prevent migraine headaches, not to treat, but to prevent the migraine headaches, it might take as much as 6 months to show full benefit. And people taking the drug for 6 months seem to do better than people who are taking the drug just for 1 month. For migraine prophylaxis, actually the tricyclic antidepressants, the amitriptyline and the nortriptyline, the second most commonly prescribed medicines after topiramate. But you have to realize that we now have all these injectable medicines that cost a heck of a lot more. But in spite of the drugs like Amivig costing a lot more, they don't necessarily provide all that much of an increase in benefit compared to the old-fashioned medicines. The effect of a drug like Nortriptyline seems to be that it has an effect against the adrenergic system, against the norepinephrine more so than the serotonin. Now, if you look at the tricyclic antidepressants, they seem to block the serotonin, they block the norepinephrine, they block a heck of a lot more. Doesn't help with tinnitus. The anxiety of Parkinson's disease might be improved in people who are taking the drug, might help with the off periods in Parkinson's disease, seems to help a little bit in those people who want to discontinue cigarette smoking, seem to be twice as effective as a placebo, but it's really only a second-line drug, and somewhere between about 5 and 10% of the people who are taking the drug for help with discontinuing tobacco smoking just discontinue the drug because they don't like it, because they have side effects from the drug. The effect, by the way, is not related to the antidepressant effect, and the SSRIs don't seem to be effective in this regard at all. Now, it seems that nortriptyline has a stronger effect on the norepinephrine and its reuptake inhibition than serotonin. On the other hand, amitriptyline seems to have an equivalent effect. If you take the drug, you probably have to take the drug 1 time a day, or sometimes 2 or 3 or even 4 times a day. You could take it either with food or without food. You should take the major dose, if you're going to divide the doses, major dose before you go to bed. And if you find that it keeps you awake, or keeps you asleep rather, the next morning, well, maybe you take it a little bit earlier in the day. Well, the tricyclic antidepressants are a novel class of drugs. They were found when they were searching for a better antipsychotic medicine after the initial success of the drug clomipramine. And clomipramine seemed to work very well, so they modified the phenothiazine ring. They put a sulfur in there, and they discovered first imipramine. That was discovered in 1959, but it didn't help for treating schizophrenia, or treating the psychoses. But it did seem that the people who took the drug had mood elevation. Matter of fact, their mood improved by about 50%. But in the 1950s and the 1960s, there were no clinical criteria established for the diagnosis of depression. Depression was anything that the physician thought it was. Unfortunately, kind of like the situation we're in now. Well, for severely depressed patients, it seems that the tricyclic antidepressants might actually work even better than the SSRIs. The type of that depression we call melancholia. The improvement and remission is more in the patients who are taking the tricyclic antidepressants. The melancholia is sometimes referred to as atypical depression. It's when people eat a lot, sleep a lot, they have a leaden feeling. There's some black boxes associated with the drug, caution that the FDA mandates, saying that any antidepressant not just the nortriptyline, but all antidepressants, might increase suicidal thinking or behavior, especially in adolescents or children or young adults. So you have to be very careful prescribing the drug. Might lead to emergence of suicidal ideations, especially if the person takes the drug and then experiences periods of anxiety or agitation or panic attacks, insomnia or irritability, hostility or impulsivity, or even mania or hypomania. If those situations develop, then extra caution is necessary. Well, you shouldn't take the drug within 14 days of taking an MAO inhibitor, could lead to the serotonin syndrome, we'll tell you about that in a moment. Shouldn't take it with other tricyclic antidepressants, again, can lead to the serotonin syndrome. You don't take it during a heart attack or during recovery from a heart attack, and if you have bipolar disorder, shouldn't take it. Now, sometimes people with bipolar disorder present with depression by itself, and you can't tell. The depression seems to be pretty much the same. So you have to take a detailed family history, detailed psychiatric history, find out if there's suicide in the family, if there's bipolar disorder. Nortriptyline is not approved for people who have depression associated with the bipolar disorder. Close observation if a person has cardiovascular disease, especially because it seems that nortriptyline can produce a very fast heart rate in some individuals and change the conduction time. So you have to be careful, especially if an individual has arrhythmias or a history of a heart attack or a stroke. It's not necessary that there's a cause and effect relationship, but there is some sort of an association. And you also have to be careful because the drug is an anticholinergic. It interferes with the acetylcholine in the body, and that's important in those people who have glaucoma or a history of urinary retention. And be careful if you have a history of seizures. It could lower the threshold for having another seizure, and if you're hyperthyroid or on thyroid replacement, might lead to cardiac arrhythmias. And it can impair your mental and physical ability that might be required for some sort of hazardous activity. So you have to be careful when you start taking the drug. If you're operating heavy machinery or driving a car, you got to be careful if you take it with alcohol because of an increased risk of either suicide or overdose. Now, we talked about the serotonin syndrome. You can get the serotonin syndrome just by taking the nortriptyline by itself or in combination with an SSRI, that's Prozac or Celexa, or an SNRI, Effexor, or the triptan that you might use for the treatment of migraine headaches. Other tricyclic antidepressants shouldn't be combined because of the serotonin syndrome, or fentanyl, or if you take lithium or tramadol, or tryptophan, or buspirone, or St. John's wort, or the MAO inhibitors. What are the symptoms of the serotonin syndrome? The symptoms of the serotonin syndrome are quite severe. Mental status changes, agitation, hallucinations, delirium and coma, autonomic instability, means your heart rate goes way up, your blood pressure is labile, goes up and down. The problem is associated with dizziness and sweating and flushing and alters your body temperature. Causes some neuromuscular changes, leads to tremor and rigidity and myoclonus, hyperreflexia, incoordination and seizures, and gastrointestinal changes like nausea and vomiting and diarrhea. In people who have schizophrenia, can either activate latent schizophrenia or worsen the psychoses if they're having them. If you treat an agitated patient or an overactive patient, might lead to even worse overactivity or anxiety or agitation. Got to be careful about the bipolar disorder because it may precipitate attacks of mania. Side effects are common and they're relatively mild, especially when you compare them to amitriptyline. And if you start off at a relatively low dose of the drug and then slowly build it up, you can develop tolerance, and they don't seem to have the severe nature that they would have if you started off at a relatively high dose. So the drug can cause some dry mouth and constipation and blurred vision, might lead to some sleepiness, and might lead to blood pressure falling when you stand up, or weakness, or drowsiness, or dizziness, or urinary frequency, or paradoxically urinary retention can cause some itch, it can cause some impotence or erectile dysfunction or loss of libido, but it does that less than the SSRIs, can lead to hostility, might change the blood sugar a little bit, either increase or decrease, can lead to weight gain, especially in older individuals, might lead to confusion or disorientation or impaired coordination. Other people might notice some nausea or vomiting or sweating. Might lead to mania, again, in those people who have bipolar disorder. Some people can find that it dilates their pupil, which might be a risk factor if a person has angle closure glaucoma. And remember we said that it interferes with the metabolism of acetylcholine? Well, that links it to potentially dementia. And that might not be reversible even after you stop taking the drug, because the acetylcholine is important in learning and memory. Now, it's associated with more severe and more serious side effects like hypertension, arrhythmias, and heart block, and heart attack and stroke and seizures, and extrapyramidal syndrome, where a person has rigidity, has a lack of facial movement, tardive dyskinesia. The bowels stop working, can interfere with manufacture of the granulocytes that you need to fight infection, can even lead to hallucinations. When you withdraw from the medicine, you can have a relatively minor disorientation syndrome with some nausea and vomiting and maybe some loss of appetite and restlessness, can lead to some insomnia or even a headache or generalized malaise or dizziness. Possibly, if you're going to have some surgery, it might be a good idea because of the potential for arrhythmias to see if you can stop the drug a couple days before the surgery. It has some interactions. It interacts with drugs that have the anticholinergic activity or the sympathomimetic activity, like if you pop a Sudafed, can exaggerate the response to alcohol. And if you're taking one of those SSRIs and you decide you want to switch to Nortriptyline, maybe you're taking Prozac or Celexa or Paxil or Zoloft, well, you should wait 5 weeks until you take Nortriptyline. So if you also are taking Nortriptyline and taking a drug that blocks the enzyme that's used to metabolize the Nortriptyline, that could lead to a pretty high concentration of the Nortriptyline in your blood system. That might lead to problems. So you got to be careful, especially taking a drug like cimetidine or the antidepressants. Those are the SSRIs. Or some drugs that you might take for arrhythmias like Rhythmol or Tambicor, or their generic equivalents. So if you need to combine the drugs, better use relatively low dose. And if you stop taking one of those other drugs, then you have to make adjustments oftentimes in the dose of the Nortriptyline. So you begin at a relatively low dose to avoid some of the side effects. If you happen to be elderly or if you're an adolescent, smaller dose. Use larger dose in inpatients than we do in outpatients. Might have an antidepressant activity, especially if we can monitor the blood level. So we want to keep the blood level somewhere between 50 and 150 nanograms per milliliter. So in people who are taking relatively higher doses, we can monitor how much of the drug is in the system. And that can give us a good idea. You can take the drug once a day or twice a day or several times a day, 3 times, 4 times a day, depending on your particular circumstances. The tricyclic antidepressants seem to have a relatively narrow therapeutic index, so it's easy to get too much, and the likelihood of a serious overdose, accidental or intentional overdose, is fairly high. And they could result in death, so you have to be very careful. The problem seems to be related to the sodium channel blockage, and that leads to this cardiotoxicity. So if you overdose, oftentimes you overdose on a combination of drugs. Well, if you have a combination of drugs, then it gets complicated. If you're taking just the Nortriptyline and you overdose, well, the toxicity can develop relatively quickly with a fall in the blood pressure and arrhythmias, and that could lead to shock and cardiac failure, pulmonary edema, fluid building up in the lungs, seizures, and central nervous system depression that shows up as a coma. Some people become confused or restless or have visual hallucinations or dilated pupils. Then there's agitation and stupor and dizziness, drowsiness, muscle rigidity. So we treat that appropriately. And sometimes it's necessary even to inject some sodium bicarbonate, because if we make the bloodstream somewhat more alkaline, then the free drug binds to protein and becomes less problematic. What kind of dose do we use? Well, we start off at a dose of 10, 25 milligrams a day. The typical dose, the ultimate dose, the maintenance dose, tends to be about 50 to 75 milligrams a day. If a person needs more than 100 milligrams a day, then we should monitor those blood levels. The blood levels to make sure they're, one, taking the drug, and two, getting the effect of the drug. And three, that they don't have some sort of an abnormality in metabolizing the drug. It's not recommended at a dose of more than 150 milligrams, and elderly individuals, adolescents, probably a dose of maybe 30 to 50 milligrams a day would be tops. Comes in a variety of strengths, comes as capsules, 10 milligram, 25, 50, and 75 milligrams, even comes as an oral solution. We have to be careful about people's ability to metabolize the drug, because if a person has some interference with those enzymes necessary to metabolize the drug might build up 8 times greater than normal in the system. Unfortunately, about 70 to 90% of people metabolize the drug normally, but when we add other kind of drugs, or in people with a genetic abnormality, they might metabolize the drug either extra fast or extra slowly. Cause problem. If they metabolize it extra rapidly, then you don't get the effect. Extra slowly, then you get the toxicity. The bioavailability of the drug is about 50%. The half-life is anywhere between 16 hours and about 2.5 days. So again, have to be careful. It's metabolized mostly in the liver by the 2D6 enzymes. Mostly goes out in the urine, only a little bit goes out in the stool. As far as pregnancy and lactation, it doesn't really have an established safety record. It appears relatively safe, but we prefer not to use these kind of drugs while people are pregnant. Pediatric groups, not really studied. In seniors, monitor for changes in the blood pressure and arrhythmias and the possibility of confusion. And also very rarely interferes with the liver function. So we do have to be careful and use the lowest dose for the shortest period of time. It blocks the norepinephrine and the serotonin reuptake. Also blocks the histamine and the acetylcholine. That means it's relatively nonspecific. Nonspecific means it has more actions, but it also means it has more side effects, as opposed to, say, the SSRIs. They're pretty specific in what they do. Well, the structure of all of the tricyclic antidepressants is pretty much the same, just a little change in a molecule or two. On the other hand, if we look at the SSRIs, they're very diverse in their structure. They just all happen to work in a similar fashion. If we compare Nortriptyline, say, to imipramine, another tricyclic antidepressant, there's less jitteriness. And compared to the other tricyclic antidepressants, there's less postural hypotension. That means when you stand up after you've been sitting a while, you don't get the feeling that you're going to faint, and you don't tend to fall. Now, how do the tricyclic antidepressants work in comparison to the SSRIs to treat depression? Well, they're about the same. All of the drugs are about 20% better than placebo. That's not great, but that's how they work. So fewer than 50% of patients who have depression are going to have a satisfactory outcome with first drug prescribed. Doesn't matter what the first drug prescribed is. Fewer than 50% going to have a great response. It's trial and error approach to the drugs. And even with multiple attempts and multiple drugs, about 1/3 of the people taking the conventional antidepressants are not going to respond. Now, sometimes it seems that depression may be associated, of course, with the psychosocial stress that can lead to inflammation. And inflammation we can measure sometimes by an increase in a chemical in the bloodstream known as C-reactive protein. And it seems that in those people who have an elevated C-reactive protein, it seems that we get a better response with the tricyclic antidepressants oftentimes than with the SSRIs. But unfortunately, the C-reactive protein elevation could be from being overweight or having an infection or some other kind of inflammatory disease, rheumatoid arthritis, something like that. Well, if you have a heart attack, the likelihood of suffering from depression is somewhere between about 15–20%. And if you suffer from depression after a heart attack, your likelihood of mortality might be increased by about twofold. So the American Heart Association recommends screening after a heart attack to see if you have depression. But they don't specifically recommend the tricyclic antidepressants. They don't specifically recommend Nortriptyline because of the potential link to the cardiovascular disease and arrhythmias. And by the way, about 80% of people who have significant chronic obstructive lung disease seem to suffer from depression. And if they take a drug like Nortriptyline, maybe the depressive symptoms go down, but it doesn't really necessarily improve the problem with breathing. Well, Nortriptyline is better tolerated and less sedating than Amitriptyline, has less drying effect on the saliva, less problem with the orthostatic hypotension, seems to be least problematic as far as drug interactions of all of the tricyclic antidepressants, seems to be better in elderly individuals than Amitriptyline. We can monitor the blood concentration in order to hopefully maintain a relatively safe level in the body. And if a person suffers from depression, it seems that the drug works more quickly than Amitriptyline. So in the first week, about 55% of the patients have some response as opposed to only about 25% with Amitriptyline. How much does it cost? Well, now that it's generic, it's relatively inexpensive. You could go buy a month worth, 10 milligrams, 30 capsules. You could get that for cash for anywhere between $12 and $17, and with a coupon from GoodRx between $4 and $8. For Nortriptyline 50 milligrams, again 30 capsules, cost anywhere between $12 and $20. If you have a coupon from GoodRx, $4 to $17. But the shocker is, even after all of these years, if you want to buy the name brand product, if you want to buy a month worth of Pamelor, it's going to cost $1,200 for a month versus $4 for the generic brand. Doesn't make any sense. That's the craziness of pricing in America. Well, anyway, that's the story of Nortriptyline or Pamelor. It's a tricyclic antidepressant used for depression, but for a variety of off-label uses, including migraine prophylaxis and insomnia and ADHD and neuropathic pain and certain forms of anxiety. But currently, the SSRIs and the SNRIs are much more popular, much safer in overdose, but they're really not more effective, at least in terms of treating depression. In fact, when we talk about treating depression, all of the drugs seem to work pretty much the same. And unfortunately, it's trial and error, with, again, fewer than 50% of patients responding very well to the first drug that is used in treatment. And in spite of all of our progress in medicine, when it comes to treating depression, we're still just in the first chapter of the book. Anyway, thanks for watching. If you enjoyed the show, please consider subscribing. Tell a friend. We'll notify you if you're a subscriber when we post new videos. I appreciate your interest. I'm Dr. Ken Landau.